Do you have time in your day to stay current with the ever-changing medical information needed to treat your patients? With your busy schedule, there can't be much. That's why nurse practitioners need UpToDate. UpToDate provides accurate, evidence-based clinical information and treatment recommendations you can trust quickly and easily. Join the growing network of over 2 million medical professionals worldwide who rely on UpToDate. Visit go.uptodate.com/NP15. That's go.uptodate.com/NP15 and use promo code NP15 to save 15% on a first-time annual or longer individual subscription. In this episode of the Nurse Practitioner Podcast, Victor Czerkasij discusses psoriasis.
Hi, thank you. This is Victor Czerkasij. So glad to be with you on this podcast on psoriasis. I'm a nurse practitioner in dermatology here in the Cleveland, Chattanooga, Tennessee area, and I have been part of the Nurse Practitioner Journal editorial board since 2008. Very happy to be with you. I see about 50, 60 patients a day. Am involved in Mohs surgery, but my primary job 100% of the day is clinical dermatology.
Thanks for your introduction, and we'll jump right into it with some of our questions today. Over the past 20 years, psoriasis has been a popular topic of conversation in the dermatology world. Specifically, we see frequent direct-to-consumer commercials and various products available in the market today. What's the latest science in diagnosing and prescribing for psoriasis?
Well, thank you. That's a great question. I can tell you we are light years where we were earlier in my career and in my lifetime. Imagine, in my professional career, I have seen us go literally from the Stone Age to the Space Age. We have had tremendous improvement in our body surface averages of people who are satisfied with maybe 30, 40% improvement of their psoriasis. Right now, we have people that are experiencing maybe 99% or even 100% improvement of their psoriasis thanks to the technology. I can also tell you this is a fantastic time to be in dermatology because not only do we have the 18 and older adult indications, but now we have what we would call a anti-TNF that is available for 4 years and older. We have a what's called an IL-1223 that is for 12 and older. And then we have two products for something that's in the IL-17 arena. And we'll be explaining all these things to you that are for 6 and older. This is huge improvement over where we used to be. Another great thing that's happened in psoriasis in just recent years is we've moved from medications that were classed as immunosuppressives to not having a black box warning at all. I mean, think of what that means for our patients and also the relief it could be for many providers who are giving these medications. So they're not considered immunosuppressives. There's no black box warning. It used to be that we had medications that were pretty tough on the body. They were oral medications. You had to take them every day. We had steroids. They would thin the skin. They would weaken the bones. They would have you put on weight. They, in fact, we've learned kind of late that steroids even worsen many cases of psoriasis over time. So we've gone from that to weekly injections, and now we have many, many products that are injections only once every 3 months. Think of that. You only have to have injections 4 times a year. That means you don't have to worry about your psoriasis 361 days of the year. Well, I mean, that's such a great place to be. Another thing I would mention is immunogenicity. We have medications that over the years, 5, 7, 10, 15, 20 years, we don't have anything but a nice straight line where they have effectiveness. It used to be that a lot of these medications dropped off. And finally, side effects are much cleaner, much neater, where we had in the past death. I mean, let's be honest, death was a possibility for some of the immunosuppressives that we had as a side effect. Now, our worst side effects are either a runny nose, injection site reaction, which can improve in a day or two, or fatigue the next day. And all of those, in study after study, in many of our biologics, disappear the longer you use it. So, yeah, I mean, the prescribing part has been tremendous, and it's a great place to be.
Can you break down the science of psoriasis? Is it more than just a skin issue?
You know, I look at history, and I wonder if it wasn't in the past, in our early civilization, like if you read the Christian Bible, you would hear stories of somebody that was unclean. They had leprosy. I wonder if that wasn't psoriasis back then, and it was just misunderstood. People all through the Middle Ages, of course, there's different pictures and paintings where they're thrown out of a city, and I really wonder if it wasn't psoriasis much of the time, because it was a skin condition. Well, we've come a long way from thinking it was a skin condition, and now we see that it's a, let me put it this way, it's a CID. For everyone listening, a CID is a chronic inflammatory disease. And we have a number of them. For example, rheumatoid arthritis is a classic chronic inflammatory disease. And what happens is there's a term that's coming out in dermatology in the last year or two, and we call it inflammaging. And, inflammation and aging. So we put them together, and we have the term inflammaging. And the longer you have circulating in your body these proteins that are overproliferating and inflaming all parts of our body, then we're just going to get really sick. And skin is one of the manifestations of the psoriasis, which I believe is a chronic inflammatory disease, as does much of science. I remember growing up as a teenager in the 70s, and they would have commercials about the heartbreak of psoriasis. Well, I've never experienced it myself, but I've seen it enough times. In fact, my master's was in psoriasis, the effects of psoriasis on the effect of moderate to severe psoriasis on human sexuality. Yeah, there was heartbreak there. You did not want to feel intimate or get close to someone. You could always see a psoriasis person that wasn't being treated well by having the long pants and long sleeves poolside. They came to the party, but they're not going to get in the water. They avoided social conditions. They were kind of like a self-imposed leprosy from 2,000 years ago. Well, what we found is that psoriasis, the very word, kind of gives away one of the aspects. It's a Greek word. It comes from the Greek psora, which means to itch, psora or psoriasis. And people with psoriasis know that it can itch a great deal. And this heartbreak, this constant inflammation, is because we have in our bodies these proteins. They're either from the interleukin family, or they're from what's called the tumor necrosis factor alpha family, or others as well. T cells are implicated as well in the immune system. So depending on the person, their genetic makeup, these people will develop these proteins, and they, instead of acting in a normal defensive manner in our immune system, start to inflame joints and skin, and increasing all kinds of comorbidities. People with untreated psoriasis or psoriatic arthritis have an increase of cancer, obesity, heart disease, increased lipids. There's complications with diabetes, stroke. I mentioned sexual dysfunction, and depression, of course, and hypertension. I mean, I can keep on going here. The thing is, if you can make the source of your spring clean, then all the waters that flow from that should be much better. And that's what we're seeing in psoriasis. When we address the immune system, where it's this overproliferation of these different proteins, if we can calm them down, then the rest of the body is going to do a lot better. I see people very, very happy over time with their treatment, because they're exercising, they feel better, they're walking, they're interacting with their friends. So yeah, it's not just a skin condition anymore once you know the science.
How do you differentiate psoriasis from other inflammatory conditions? Is psoriasis often misdiagnosed? And what tips would you give to a provider to correctly diagnose psoriasis?
Once again, a great question. And we find that for the most part, for those of us in dermatology, since this is what we do for a living, we will have the diagnosis fortunately correct. But I will tell you honestly, there has been a few times in my career where I did think it was psoriasis, and then I had to do a punch biopsy. And it was, in fact, a very severe case of seborrheic dermatitis. That's a classic differential of yeast. In fact, many of my doctor referrals that I take every day will tell me that they have a patient that's not responding to their seborrheic dermatitis treatment, which, for those of you not in dermatology, sebderm, as we call it in the vernacular, is a cradle cap. It's an overgrowth of yeast. And one of the key ways that you can tell the difference between psoriasis and seborrheic dermatitis is the Auspitz sign. It's spelled Auspitz, Auspitz, someone very famous a long time ago whose last name was Auspitz. You know how these people with the hard names, I don't know if we'll ever have a Czerkasij sign, but the Auspitz sign is where you just pick it with your fingernail, and I have a glove on, and if it does not bleed, it's seborrheic dermatitis. It's the overgrowth of yeast. If it does bleed and you haven't hurt the patient, then, which we don't, they traditionally don't feel it. But then if it bleeds, we're pretty sure we have psoriasis. Another thing is I've also biopsied in my career psoriasis because it wasn't responding, and it was mycosis fungoides, which is a pretty aggressive, destructive skin disorder, which requires a completely different treatment paradigm. So always think to yourself, don't be hard-headed. I remind everyone that I train around me. If the medication is not doing its job, if the psoriasis is not responding, swallow your pride and try to figure it out. Also, don't forget, there are 5 different forms of psoriasis. What I'm talking about in this podcast is plaque psoriasis, which makes up 80% of the psoriasis family. But, you know, we have a broad range. There's guttate psoriasis, there's inverse psoriasis, and then, of course, it goes all the way over to erythrodermic psoriasis, which is really a cutaneous emergency that we have to treat. Now we are also getting different books, textbooks, and the latest journals that are saying that you can also have your own entity with scalp psoriasis or fingernail psoriasis or groin psoriasis. So yeah, you know, it's always changing, and we're trying to stay ahead of where the science is taking us. So right, usually it's seborrheic dermatitis, but there's one more, eczema. Always watch out for eczema, because what's tricky is that eczema and psoriasis in the early stages, if you've misdiagnosed it, they're both usually treated the same way, and they'll respond positively. But before you go too far down that road, it's always good to have that correct diagnosis. And seeing a lot of patients every day over the decades, I think will help you get better at it.
Can you describe the Koebner phenomena in relation to psoriasis?
Yes. So here's another person that got their name famous because they figured out something, and now we, of course, name it after them. But Heinrich Koebner, Koebner, from all the way back in 1876. He was well known for seeing a really interesting phenomena, and that was Koebnerization, as it was named. And bottom line, what happened was you'd have a person that was going through their life, everything was happy for them, they were enjoying their horse and buggy days, but all of a sudden they would develop in previously unaffected skin psoriasis. Now, how did that happen? So today we still see this phenomena in healthcare, or in dermatology in particular, and I've seen it a few times in my career. Koebnerization, you may not have any family history of psoriasis, and so you're going through your life and you're standing up on a small stool because you're short in the kitchen, you want breakfast. This is a true story of one of my patients, and she was reaching up, and the stool slipped out from underneath her, and she banged her head on the granite countertop, really hurt herself. So, she went to the emergency room. They sewed up the small cut and everything was fine. As it was healing, they noticed that there was this red, silvery plaque that started to develop there, and she started to lose hair because of that inflammation. So they sent her to me. And I was able to diagnose her correctly with Kebnerization or plaque psoriasis. So the trauma from knocking her head on the granite caused psoriasis to come up. So there must have been some kind of predilection or propensity in her immune system. Basically, it's an overproliferation of the body to make skin, and it leads into psoriasis, which, as we can tell you, is not curable. So she was pretty frustrated. I'll tell you another couple times this has happened is they were both women who went for delivery of their child and ended up with cesarean or C-sections. And well, right on the C-section line, right there along the panty line or a little bit below, they developed silvery, reddish, thick line of it looked like a rope of a plaque, and that was in fact psoriasis. I mean, go figure, Kebnerization. So whereas Heinrich Kebner did not in fact invent Kebnerization, he made that observation, and to this day we use his name to see that. I've also seen in a hospital situation where someone received a graft for a burn, and that's where they developed psoriasis. So they use that term now for any number of changes from the original skin, but the classic understanding is psoriasis. So very strange, very curious. And what can we do in the early stages? I'm pretty aggressive with steroid, and so I try to limit how that occurs. There's another area in dermatology where trauma causes trouble, and that's squamous cell. We do have people who undergo wounds or cuts or trauma. They were in a car accident. They were going through the woods camping, and a stick stuck them, and squamous cell will develop from that area. So that's not the only condition in the body that responds in a unusual manner from normally clear skin.
Earlier, you mentioned biologics. Would you mind elaborating more on this growing area of medicine, especially during COVID? How safe are the various forms of biologics given the recent mutations of COVID and with the vaccines in general?
Thank you again. So yes, we are still during the time of this podcast with different variants of the COVID-19, and we're still plowing ahead, trying to make sense of what this means to healthcare at large, as well as what does it mean for us in dermatology, and what about psoriasis? So some things that I've been noticing, along with many, many others nationwide, and we're trying to have a registry, is the unusual cutaneous reactions that occur from having COVID-19, or even the vaccine sometimes. That is a reality, though overall they've been proven to be safe and effective. But that said, with COVID-19, we're seeing, for example, hair loss, particularly in women. We're seeing unusual rashes, the public would say. We would call it allergic urticaria. But also, is it safe to be on a biologic which works to amend your immune system during this time? So let me give you the official line from the American Academy of Dermatology, the CDC, and also the National Psoriasis Foundation, and myself, because when this all started back in, I guess it was March, April of 2020, when the public was told, give us 2 weeks to flatten the curve, I had patients that were coming in, doing telederm, saying, should I remain on my biologic during COVID-19? Well, I thought this through, and I said, based on the science, and I'll explain in a moment, keep going. And here's why. If you have a chronic inflammatory disease like psoriasis or psoriatic arthritis or rheumatoid arthritis, and you run up against an illness like COVID-19, it's very likely that your body is going to be primed for an overreaction. Remember, you're already in a certain way with a hurt immune system when you have psoriasis, right? You're having an overreaction, an overproliferation of these important T helper cells, tumor necrosis factor alpha, interleukins. and you run up against that, you get very ill, and your body can overreact, right? We already know about comorbidity. So I thought it through, and we have come to a determination in healthcare that we need to keep our patients on biologics, because if you can have an immune system that is, I guess the word I remember once when I was in high school is copacetic, or kind of normal, then you're not going to have that overreaction. Now, it's not foolproof, but I do have here some data on the guidance that there is no evidence right now. This is a statement that's being given by the National Psoriasis Foundation to support stopping biologics or other systemic agents with our patients during this pandemic. So we still want to be very careful. There's no guidance there's nothing to tell us that we would be using hydroxychloroquine or chloroquine for the prevention of this COVID-19 or anti-malarial. So, the science right now is go ahead, look at your patients on a case-by-case basis, look to them for a discussion that's a risk versus benefit. And for the majority of my patients, we've kept them on, and we have done just fine. And I have hundreds upon hundreds of patients on these medications, and overall, they have done very, very well. So it's a great question. It's very relevant during this time. And right now, with COVID-19, and the vaccines that are being given, we are not seeing any kind of contraindication with the biologics that we're giving to our patients for psoriasis.
Why can't we go back to using traditional drugs like methotrexate, prednisone, or cyclosporin for psoriasis treatment? Aren't they less expensive and somewhat more reliable? What are your thoughts on biosimilars?
We have, over the years, come to a place where we find that our patients appreciate not only an improvement in their skin, which some of the older drugs were very good at doing, but we have lower toxicity as well. So what has happened in the last decade in particular is we have been able to increase effectiveness and decrease toxicity as opposed to those older medications. Now, while I may personally have had a very, very good run in my career with a product like cyclosporin or acitretin, which is a vitamin A product related to Accutane, which is the brand for a brand name for isotretinoin used for the last 40 years in acne, or methotrexate, which is an immunosuppressant used for liver and kidney transplants. They were very, very good in the 70s and 80s, but now we've come to a place where for our patients, it's going to be a lot better because of the decrease in toxicity. Plus, we don't have to have the labs like we used to. Let me give you an example. So if I was going to put someone on say, methotrexate, I'm just picking one out of the hat there. So great drug. They used to do liver, kidney transplants with that, and noticed that if the patient had psoriasis, they would also improve. And they were like, wow, it's like the old Viagra story. Viagra was a cardiac medication, and they noticed it had a very unusual side effect. And they realized, forget the heart, we're going to go for this instead. And they've made billions of dollars on the side effects. So with methotrexate, we realized rather quickly as an anti-inflammatory, it worked very, very well too. But there are many, many cases where a person who never tried methotrexate died as a result a week or two later. I know that's a fact. I know of people that were providers and gave that, and they were exonerated. It was a terrible thing, but it was worse for the patient. So it's the toxicity aspect. But let's say we take methotrexate. So I have to order all kinds of labs, blood work. There was also in the early biologics that were immunosuppressants. We had to order a TB test. We had to order the HIV, Hep B, Hep C. We would have to repeat that every year. With methotrexate, you have to do a liver biopsy every, 5 to 10 years. And that was expensive and painful. And now we just don't have to do that. So some of the people will tell me, well, you're giving me something that sounds a little suspicious. I heard it's an injection. I'm a little nervous of the injection. I say, you know why? You want a pill, don't you? Oh, yeah, I think pills are maybe the better way to go. And I go, listen to me. There are lots of pills that will hurt you a great deal. But now with our injectables, the biologics, I don't even have a black box warning. You're afraid because it is an injection. Well, biologics are so fragile that if you took the medication by mouth, the stomach enzymes would destroy it. So we have to bypass your stomach. And once you explain to providers and also to patients why we're doing what we do, this timely information will be very good. Now, you asked, I think it was a moment ago, also about biosimilars. So what does that mean? Well, we're coming into the era. In fact, I would say 2022 will be the first biosimilars, which will be the generics to the many branded products that we have to the psoriasis biologics. Well, the biologics that we have gone through heavy duty trials. Some of them could cost hundreds of millions of dollars to prove their safety before the FDA, which is only right. But now the biosimilars are coming along, and they're chemically identical to their branded counterparts, so to speak. So it's assumed that their safety will be as good as before. But as anybody knows, bioequivalence or biosimilar, it's never exactly the same. It's like going to the wedding and you notice that the bridegroom is late, and just to keep the party going, and make sure you get to the reception on time, just go ahead and marry the best man, right? But the bride would say, well, I really wanted the groom. And we're like, come on, look, he's a nice guy. He kind of looks similar. She's like, well, I really wanted the groom. Well, he's not here. We got to move on. So I get a little worried about these biosimilars that are coming up. I may not be the first to prescribe that personally. I don't think they're going to be any less expensive to create I believe myself, and the safety is going to be projected and assumed. So, yeah, FDA says it's got to be safe, pure, and potent, just like the similar. And we always ask, well, how similar? And they're like, close. Well, maybe close is not enough. So this is a really good discussion. I think it was a great question because I really don't have a lot of answers to this one, and I don't think a lot of the rest of folks in dermatology do either. I think we're all waiting for the other person to go first with them. So I'm just going to wait and see on the biosimilars. And why I don't use the old drugs is simple toxicity. And remember, we all have to do 3 things every day with our patients. Number 1, we got to treat them safely is number 1. Number 2, effectively, yeah, I'll grant you that. You can't just treat someone safe and not effectively. You wasted their time and money. And then access is the third one. Make sure they get the medication. But thank you, Taylor. Good question. What else do you have for me?
Can you also elaborate on psoriatic arthritis? Do all patients with psoriasis eventually develop psoriatic arthritis? And how can we best treat that condition?
Oh, you just hit on something that is really my passion, because psoriatic arthritis is the counterpart to psoriasis. We all think that psoriasis is its own entity, but remember I told you earlier that this is a chronic inflammatory disease, and it's got 2 parts. This is the Dr. Jekyll, Mr. Hyde part, because I always, with all my patients, and I know someone listening, particularly in dermatology, is going to roll their eyes on me on this one, but I always assume that even though I'm treating your plaque skin psoriasis, you may have percolating still beneath psoriatic arthritis. And the ethical thing to do is to assess you for that. And let me give you some figures. This is right off the top of my head because I was just reading this the other day. I could tell you that 3-4% of the American population has psoriasis. And about 30%, 35%, depending on the research you read, of all psoriasis patients have psoriatic arthritis that's fairly active. That's why they feel so good. They'll come in and say, just fix my skin. And I assess them for psoriatic arthritis, and I'll give them something that also covers, psoriatic arthritis. And they'll come back a month or 2 months later and they'll say, wow, not only do I look better, but I feel better too. I don't have that morning stiffness. I don't have that joint ache. I'm not so tired like I used to be. And I'm like, hey, how about that? There you go. One of the best ways to assess for psoriatic arthritis is the PEST questionnaire. PEST, P-E-S-T, stands for Psoriasis Epidemiological Screening Test. And what the PEST test does for us is it asks 5 simple questions, just 5. And of these 5 questions, if you're positive for 3 of them, the validity is really off the charts. It's very, very good for nailing down psoriatic arthritis. And we should not forget that. I read in one survey that half of dermatology providers, it's a shame to the profession, never assess their psoriasis patient for psoriatic arthritis. So I would say this, always assume that a psoriasis patient has psoriatic arthritis in the background. And number 2, if they are positive with 3 out of the 5 questions on the PEST. Oh, by the way, another reason the PEST is such a great one is it's the only one that's non-proprietary. You can use it for free. You don't have to pay any kind of fees for using it. So, it's out there for anyone to use. You can look that up. It's a quite easy test to administer. Just 5 questions. Question number 1. Do your fingernails or toenails have holes or pits? Number 2, do you have any swollen joints like fingers, toes, wrists, ankles, or knees? 3, do you have pain in your heel? 4, have you ever had a finger or toe that was completely swollen? And 5, have you ever been diagnosed with arthritis? And if they're positive for 3 out of the 5, then give them a medication that is approved for both psoriasis and psoriatic arthritis. You're covered. And your patient's covered. And I really, really think that's the way to go. So just because you don't see the plaques anymore, don't think your job is done. Always make sure to be thorough in your work with your patients. So look for that right medication.
So let's say I'm a patient diagnosed with psoriasis, but I don't want medication. Do you have options available for me that are readily based on science? And what kind of research can you give me for lifestyle changes?
Well, look at that. I just finished my last statement to your question by saying give them the best medication, and now you're asking me what if you don't want medication? That's a really good question. So I happen to be a provider that really, really looks to the food aisle as easily as I do to the medication aisle. I really think that many of our conditions in America, even outside of dermatology, can be best addressed through diet and exercise and lifestyle changes and modifications. But I know my fellow Americans, we like our holidays with lots of food. I have a cheesecake right now. I had a few bites before this podcast that I enjoyed very much. Is it good for me? Yeah, once in a while a bite's okay. Shouldn't be eating it every day. So lifestyle modifications are something that I offer every one of my psoriasis patients. And you asked, is it based on the science or what research? Okay, I'm going to tell you right now. Are you ready? Everyone listening? This is it. The Mediterranean diet, hands down, is our best researched diet for when it comes to an adjunct therapy or lifestyle modification to psoriasis or psoriatic arthritis. It's not the Ornish diet. It's not South Beach. It's not that one with a lot of protein. It's the Mediterranean diet. And in fact, if you looked around the world, go on the internet and put in the blue zones. And blue zones are areas in the world where people live healthier and longer and happier. And why is that? And the common denominator is Mediterranean diet. And I can just tell you simply, it's if you can get a Mediterranean diet pyramid online, look for the Mediterranean diet shopping list, and then look for a number of textbooks. There's some really good ones on Mediterranean diet meal plans. And I'm going to go ahead and I should probably at this point, for all due confession, and I happen to be a Mediterranean diet eater myself. I'm married to someone who does that. My parents are Mediterranean diet people. They're 93 years old, and one takes 2 medications and the other one, I think, just 1. So Mediterranean diet is a really good emphasis on whole grains, high fiber, fresh fruits and vegetables, olive oil for our fats, nuts for protein, It's low on chicken and fish just once a week, and a red meat only once a month, which I just turned everybody's, many people's diets upside down. I will also mention it's low on sugar. Dessert only maybe once or twice a week. So that cheesecake can go a long time for me. And exercise, Tai Chi or yoga or walking, which is my favorite. I work in the yard. And, you're going to feel better, you're going to live happier, and you're going to really work on those comorbidities. So the Mediterranean diet is really based on the science, where people, in fact, there's trials where people will get the medication, and also they'll have the Mediterranean diet. And then they've also had the medication alone. And guess who was better on pain at the end of 1 month? Or I'm sorry, 3 months or 6 months? It was those who modified their diet along with the pharmacology, and they just felt better. Now, I will tell patients the Mediterranean diet, and some are very excited, and they're like, that's what I was looking for. Great. So, be prepared to answer that question. Others stare at me like I've grown a second head, and they'll say, hey, I have bacon for breakfast, chicken for lunch, and steak for supper. This isn't for me. And I'll go, okay, well, at least we tried. I'm still here to talk to you about it. Let me know how that's working for you over time, because the medication can only go so far. But I really, really think a great conversation with our patients, in fact, includes lifestyle changes based on the science Mediterranean diet.
What does the future look like for psoriasis in terms of coming to a cure or more effective, safer treatments?
I just read an article in Dermatology Times, and they wondered if it was one of those op-eds, and the doctor was saying that I wonder if we're not 10 years away, maybe 15, 20 years at the most, away from a cure. The problem with a cure is we could completely turn off these proteins that are the trigger and cause for proliferation of skin cells known as psoriasis, but they're there for a purpose. Right? So we cannot just shut these off because they serve a purpose, but we're getting down on the nitty gritty, the DNA, the genetics of it all, and it's getting really, really close to maybe even a cure, they're saying. So until that time comes, we do have a great area with the biologics. In particular, I really, really like the IL-17s. I like the IL-12/23, and I like the IL-23s. There's a bunch of medications in each of those families that work really, really well. In fact, in 2022, we have a medication, a biologic for psoriasis coming out that's safe in pregnancy. Safe in pregnancy. I mean, that who would have thought that possible even just a few years ago? So, lots of things on the horizon. We have new topicals that have a completely different action that are non-steroidal that are coming out. So we're at a point that I can safely tell you that you should be able to get your psoriasis patient not 40% improved, not 50% improved, but like the National Psoriasis Foundation says, you should get your patients to 1% psoriasis on the body or less. And that's with the technology we have available. So yeah, it's a good time. It's a good time.
It seems like there's been tremendous progress in psoriasis treatment, which is great news for patients. Do you have any final thoughts?
I do. I know I've gone a little long today because I'm pretty passionate, and also it's what I do. I really, really enjoy psoriasis and helping people. So let me kind of summarize it by telling you my final thoughts. Number one, consider diet. Absolutely. Have diet modification ready to go for any patient that might want to ask, or offer it to them so they have something to think about. Number two, I would say, please remember to assess for psoriatic arthritis. Don't just assume that psoriasis is your one and done. Understand that they may look good, but ask how they're feeling as well to do the pest test. I would say three, do a biopsy if it's not improving. There's no shame in that because there's just different presentations, especially skin of color, right? Ethnic skin. So you have people coming from all kinds of backgrounds and races, and it could be subtle in some and more obvious in others. So take the time to really assess every one of your patients and be sure to biopsy. I would say if I had a fourth final, I thought it would be don't allow insurance to pressure you in how you should best treat your patients, right? So maybe they'll give you a little hard time and push back on those prior authorizations and say, well, why don't you give the methotrexate or cyclosporin? Well, it's like me telling my sons when they were ready to drive, boys, I've got the Honda Accord or the Toyota Camry, I've got the airbags, but I'll give you guys the Model T. There's no back brace for your neck and there's no seat belts, but hey, it'll get you to where you want to go. Just don't get in an accident. I love my patients as much as my family, right? So I would not give it to my family. Some of the old immunosuppressants when I have the safer products right now with all the bells and whistles and don't have to do that kind of labs like I used to in the past. Finally, I would say one more thought, and that is we have a problem in dermatology, and I hope they address this, where they say mild, moderate, or severe. And I just think it's completely bogus today when they say that mild is 1 to 3%, and then 4 to 7% is moderate, and then like 8% and higher, or 10% and higher, depending what textbook you read, is severe. And I'm going to tell you why. I have got people that come in and they only have 1 or 2% psoriasis. And you're right now thinking, well, that's good. No, it's in their groin. It's in their armpit. It's under their breast. It's in the most sensitive areas of the body. And so when I talk to a insurance company, they're like, you don't need a biologic. You can just put steroid there. No, you can't. You cannot do that safely. So we need a biologic. So don't think that 1 or 2% is a happy thing, depending on location. It's like real estate. Location makes all the difference on the house you buy. It'll make a big difference on the product that you write for your patient as well.
Thanks for listening, everyone. You can find Victor on LinkedIn and on Facebook in the Dermatology Nurse Practitioners group. And you can also find the Nurse Practitioner Journal on Instagram, Twitter, and LinkedIn. This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed in this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer.